Good afternoon, everyone. First of all, I would like to thank the organizers, to thank the scientific committee, and to thank my friends for the invitation. I feel very honored and privileged to be here with you today. So the purpose of my first talk is to discuss the vision for radiation oncology of metastasis-directed therapy. So this is the agenda of my talk. We will discuss briefly the definition, which was discussed previously by my colleague from Barcelona, randomized evidence to date, exploring the biological rationale for metastasis-directed therapy briefly, and emerging management principles guided by biology. And the next steps, how to move forward, and what are the next steps for MDT. So definition of oligometastatic disease. It is quite ambiguous because as defined initially by Samuel Hellman and Ralph Weichelbaum from University of Chicago in the mid-90s, it was said that it could be 1 to 3. But if you look at the data from literature, from randomized studies, sometimes it's 1 to 4, 1 to 5, 1 to few, but most often few to 1 organs. But what do we do if we have few to few organs? We don't know. And as it was said before, it is not quite clear how to select the patient just based on imaging. So when we started MDT, we started simply with a oligometastatic disease, 1, 2, 3, 4, in the metachronous setting. But afterward, the medical oncologists, when they saw that it works, they pushed the limit of MDT. And when they observed an oligoprogressive or an oligorecurrent disease during the tumor board, they asked the radiation oncologist to do SBRT because they had no more lines of systemic therapy, or they expect to do a therapeutic window. And at the beginning, we said, no, we don't know what we do. We only do the metachronous oligometastatic state. But afterward, it works. And this is what led to the definition proposed by the European Society of Radiation Oncology and the European Organization for Research and Treatment of Cancer, with different scenarios, which shows what? Which shows that it's a time course of cancer with different moments, different points during the time course where SBRT could be efficient. And more than that, it shows that it's not only a time course that should be considered more than a number of metastases, but the kinetic of the disease. And it was shown by the University of Chicago. You can see that the overall survival, when you count the number of new mets per year, compared to a higher number of new mets per year, is significantly really different, 63 compared to 18 months in this study. So how to count when you're human? It depends on which kind of imaging you use. Conventional imaging, in most of the studies. Nowadays, in more recent studies, we use functional imaging, new imaging modalities. But the human reader, are we able to define correctly an oligometastatic disease just on imaging when you see that artificial intelligence can see a much more burden than what we see humans? So the more you see, the less you know. Randomized evidence to date. So there is a bunch of randomized data now showing a benefit. It has been said by my colleague. We know that David Palma with the Saber comet was the first to show an overall survival benefit, but it was different primary cancers. But if you look nowadays, we won't go through all the data. This is a summary which shows the benefit. And you can see now, most often, metastasis-directed therapy is delivered with SBRT. And you can show that for non-small cell lung cancer, prostate cancer, colorectal cancer, esophageal cancer, pancreatic cancer, breast cancer, most often we observed at least a progression-free survival and sometimes even an overall survival benefit, with few studies which were negative, but most of them were positive. So we are now exploring the biological rationale for SBRT. And it is a controversial issue because we have different thinkings with medical oncologists. Medical oncologists, they use cytotoxics to target molecular pathways to have a biologically guided therapy, and this allows them to personalize the treatment. The radiation oncologists use imaging to guide the treatment, to guide the ablative therapy delivered with SBRT, and this is precision medicine, this is targeted therapy. So we also do deliver personalized medicine with precision medicine, but it's mainly guided by new imaging, but not biology, which is cruelly missing. So if biology interests you, it's complicated. So this is a nice review you could read, and I recommend, which explains the issue we have to keep in mind, the radiation oncologist, when delivering SBRT, because we have two ways of progressions of the disease: a linear progression and a parallel progression. And both models depend on the clonal heterogeneity, and it was said previously also by my colleague. So it's really complicated because in the first case, on the top of this slide, in a linear model, when you have a clone which progresses, it can give new metastasis, but it's linearly because it's the same clone which give new metastasis. When the clonal heterogeneity appears, a previous metastase transforms in another metastase, and it becomes a polymetastatic disease. So you can have different time course depending on that, and we will further discuss this on the next slide. This is a single case study from a prostate cancer. Maybe some of you know this famous study. This is the study from a patient who dies from his prostate cancer 17 years after the initial diagnosis. And they look at the genomic mutations in the primary tumor, in the nodes, and in the metastasis. And you can see that this is a very low progression of the disease, 17 years before dying from prostate cancer. And they were able to identify the mutations in the metastases at the end of the disease, and where did it come from in the primary tumor. And you can see that the mutations observed in the positive lymph node or in the other parts of the primary cancer were not lethal. So this study is also well known. This is a genomic analysis based on 10 patients, which shows that metastasis seed other metastasis. My colleagues also showed it. And you can see this time course of the disease, which can become polyclonal seeding at the end, where the systemic therapy is more efficient than any local therapy, and a linear progression at the beginning of the disease, with a monoclonal seeding, where local therapy could be more efficient than systemic therapy. And this is what is really difficult for us to decide and to choose when prescribing stereotactic radiations with or without a systemic therapy. So this hypothesis allows for Saber, we can consider that Saber can prune the phylogenetic trees of metastasis, depending on which time point of the course of the disease it is performed. So emerging management principles now. So different principles should be considered. We discuss ablating all metastasis. Should we ablate all metastasis or not? Having the primary tumor controlled or resected, maximize safety and tolerability, and this could be done now safely with SBRT with very few toxicities. So this is a very good treatment which allows to minimize treatment time. Besides, it's also very cost efficient compared to other systemic therapies. But the next step, and the most important, regarding what I discussed before, is the selection of patients regarding this biology. So if you look at the Norton-Simon hypothesis, the lower the tumor burden, the higher the effectiveness of a systemic therapy. So if you deliver an SBRT even on a polymetastatic disease to decrease the tumor burden, you could help the medical oncologist to have a better, efficient systemic therapy. And this paves the way for combining treatments and for multimodal therapy. So, having said that, now we deliver more and more stereotactic radiotherapy, oligorecurrent, oligoprogressive in the polymetastatic disease, and it really changed the way of thinking of the radiation oncologist. And now radiation oncology delivered with SBRT is just to me, just like lines of radiation oncology, like medical oncologists could deliver line or course of systemic therapy. And could it improve survival? We don't know. But this is a retrospective series from the University of Zurich and the group of Matthias Guckenberger, which shows that if you deliver more than 5 courses of radiotherapy, you could have an impact on survival. For sure, the more you deliver, the higher the number of courses of the radiotherapy, the more palliative the courses are. But now with SBRT, if we improve the local control and we deliver more and more lines of stereotactic radiation therapy, one may expect to have a significant improvement, maybe on survival. So synchronous versus metachronous, oligomets or metachronous polymets. For sure, everybody knows that de novo metastases have a worse prognosis compared to metachronous prognosis. So this is the case of prostate cancer, radiological progression-free survival, castration-resistant cancer survival, and overall survival. And when you have an oligometastatic metachronous disease, the prognosis is good. It's similar to a patient with a biochemical failure. Once you have a polymetastatic disease, the prognosis gets worse, and even worse when it's a de novo metastatic disease. But if you look at the biology, and if you look, for example, at this biomarker, famous biomarker TP53 in prostate cancer, you can see that patients who have a wild-type TP53 are really better than patients with a mutated TP53. And if you look at the setting of patients, metachronous, polymetastatic, oligometastatic, you can now consider, for instance, that a patient with a polymetastatic disease, but a wild-type TP53 disease, has a better prognosis than an oligometastatic patient with a wild type, which shows that we truly lack biomarkers, biology, to select our patients. So this is the translational studies from the SAFFRON-2 randomized study published by Shankar Siva in the JAMA Oncology trial. So you can find the results of the translational study in the full paper, but mainly in the supplementary. And this is really interesting because what they found that whatever the fractionation schedule delivered in this study, 1 fraction or 4 fraction, SBRT could induce changes in circulating immune cells or even plasma cytokine levels. And this could be observed with different profiles depending on whether the patient is controlled or patients will have a progression of the disease. So we can now identify biomarkers that could better select and guide radiation oncologists for delivering SBRT. This is another randomized study from the group of the MD Anderson and Chatham, which also showed that local consolidative therapy delivered with SBRT could decrease the immune cells, but decrease the circulating tumor DNA. Phase 3 randomized trials, so present and future. We discussed the number of metastases in what was published in randomized trials, sometimes 3, sometimes 4, sometimes 5 metastases. So we have Saber Comet 3, but the next step, and it is currently, we expect the result of the Saber Comet 10, and now we expect to know if we have a benefit when delivering SBRT to more than 4 and less than 11 metastases. And the next step is whether SBRT is useful and beneficial for patients with more than 10 metastases. So the primary endpoint of the Saber Comet 10 is overall survival, and the results are expected. The ARREST trial is a really interesting, amazing trial. It is really a paradigm shift. So patients included in this trial should have 10 or more metastatic lesions with a life expectancy of at least 3 months. You have the different levels to deliver SBRT to all the metastases, at least 10. And this is really a new way of prescribing SBRT, because if we move forward SBRT to the polymetastatic disease, it's going to be much more complicated to respect those constraints. So now you have trade-offs that must be made, and it could be accepted to treat some metastatic lesions with only the GTV covered by at 95% by 95% of the prescribed dose. So this is really amazing and a real paradigm shift. The ARREST-2 trial is a randomized trial which will compare standard of care, which could include standard palliative radiotherapy, to the same standard of care plus SBRT to at least 90% of the targets. Not all the targets, but at least 90%. And they expect to see if a benefit in overall survival by just treating at least 90% of the targets could be observed with SBRT. Could it be done? Because it's really amazing. So they did dosimetric studies. You can see some dosimetric studies on 2 patients with 24 mets, 30 mets, 50 mets, and you can see that beam on time is ranging between 18 and 29 minutes per 6 gray fractions. So it could be delivered, and we'll see what are the results of the rest 2 trials. So in conclusion, the current landscape of phase 3 trial randomized evidence trials favors MDT, and the evidence is growing up. Biological and phylogenetic analysis provide theoretical rationale for metastasis-directed SBRT, allowing to prune the phylogenetic trees to cut the branches of the cancer. Collaborative multi-platform and translational studies are underway, like what was performed in the SAFFRON-2 trial or in the MD Anderson trial. And this will allow to find biomarkers to better select the patients for SBRT. And the next generation, I showed you that the next generation of randomized trial are really amazing, and we are moving forward to the polymetastatic disease right now. Thank you very much.